It is severe because he can't do any weight-bearing activities. He can't do any weight-bearing activities. So it is severe. And it is irritable. Because once he just do some weighting activities for 10 meters, he feels the symptoms. So it is irritable. What does it mean for you? Lumbar spine. Are you all okay with that? Yeah. Starting, come on, the center is here. Can you start with lumbar spine? You must start with lumbar spine. Well done. Yeah, you must start with lumbar spine. Why? Because if you start with the hip and later on the patient is not improving, you have to go up again and assess the lumbar spine. So from today, it's super easy to take 2 minutes. Now, how can we assess? It's 4th day, now we are having the same language, so we'll make it slightly more advanced now. Sometimes, if the symptoms is here, and you need to know if the problem is lumbar spine or not, straight away do the repeated movement testing. Right? Straight away do the repeated movement testing. So, now, the patient did 10 flexions, no effect on the symptoms. How did you know? He did 10 flexions, so I asked him to walk. No, still there. So flexion has 0 effect. Side flexion to the left, extension repeatedly has no effect. Side flexion to the right has no effect. Lumbar spine is out. So if the repeated movement test of the spine has no effect on the symptoms on the periphery, that means we can say that the spine is out. How can we assess the hip? Imagine you are in your own clinic and you have a patient with hip problem. What are the basics of assessment of any joint? Active and passive range. Good? Now just follow me please. Weight-bearing activities is painful. Are you going to assess the range of movement in weight-bearing today? No, non-weight-bearing. That's why here we do the active range and the passive range in loaded, weight-bearing, and unloaded. But if the patient's symptoms is not severe, not irritable, and not with weight-bearing, I can assess the active and passive range in loaded position or weight-bearing position. Okay? Now let's do that and imagine we have the same scenario. Would you mind to help me please? Now we do assessment of the active range and the passive range of the overpressure in standing, weight bearing. Okay? Not for this patient. I'm just doing this as a general demonstration. Okay? Can you just face me please? And you are my colleague as a therapist, I'm the patient. The patient will place a hand on the top of the therapist's shoulder and will place your hand on my head, on my ear, on my ear. Good? Now, I'm testing the range of movement of rotation on the right hand. So I will bend my left knee and you place me my knee. And you will move to that direction and I will follow you. Yeah, can you move? Yeah, move your whole body. Sorry, it's my fault. This whole. Bend your knee. I'm the therapist, he's the patient. Just follow me. Now I'm testing rotation of the hip in loaded position. At this point, he felt some symptoms. I will do touch and go. So the same. So I'm testing the active range of movement. If you have some symptoms, I will do some desensitization from this point. Can you summarize that?
Jadi kalau misalkan kan ada dua aktif physical examination untuk di hip itu ada yang loaded atau diberikan beban kepada salah satu daripada tungkainya atau unloaded. Jadi posisinya tidak ada bebanan sama sekali. Untuk dengan klien yang memiliki nyeri, jika tidak ada nyeri berarti kita bisa pakai yang loaded. Tapi kalau misalkan dengan klien yang nyeri, kalau misalkan kita memberikan tumpuan berarti kita pakai yang unloaded. Terus kalau misalkan dengan klien yang tidak ada nyeri di saat diberikan pembebanan berarti kita bisa melakukan active yang range of motion dengan posisi loaded itu dengan cara yang tadi. Jadi salah satu kaki diangkat atau lututnya ditekuk, lalu posisinya dia bisa pegangan di bahu kita pegang di area pelviknya, lalu kita bawa putar putar ke dalam sehingga lututnya sehingga tungkainya atau hipnya berarti ke putar keluar ke dalam ke luar. Jadi kalau misalkan kita masuk ke dalam berarti
it doesn't matter the internal extent. We are doing both.
Yeah. Berarti bisa dua-duanya.
Okay? Yeah. Good. So we'll do it again. Bend your knee. Now is one direction, but also will go to other direction. Foot should be stable, shouldn't move. The only problem, I cannot do this test for a patient who have knee problem because a lot of twisting on it. Are you okay? So this will be active range. At the end, if there's any limitation, I can do touch and go as a desensitization. Assessment, treatment. Are you alright? So this is for rotation. Then what? You are the therapist, I'm the patient. The therapist has to follow the patient. If the therapist goes first, I will twist my lumbar spine. You know what I mean? So we have to go together as one unit. Excellent. That's nice. He's moving with me. Now, I feel some limitation. Shall we do some touch and go? Excellent. Easy. Thank you so much. Thank you. So, and the good thing about this, if the patient is not highly irritable, that it can desensitize the symptoms very well. Because if the patient has the symptoms in loading, it's nice to talk to the nociceptors, the pain receptors, in loading. Are you okay? So this will be active range of movement into rotation. Rotation. Now, for flexion, I will draw a line. I will be testing flexion on the right side. Flexion on the right side. I'll just go with lunges. Yeah? Now, I'm testing flexion on this side. What if the patient has some symptoms? He can do touch and go for himself as a self-mobilization, or so we want to come back and do lunges from your face. Good. Now, at this point, can you go down to touch here? At this point, you feel some symptoms here. I can do touch and go by placing my hand. By placing my hand in the ilium, one hand in the ilium, one hand in the greater tubercle, and just push and back, push and back, push and back. I'm here to support him. It's not a bad idea to have a chair and he hold the chair. The hand in the ilium, the hand in the greater tubercle. That means the both parts of the hip are moving. Good? So I'll come here, one hand in the ilium, one hand in the greater tuberosity, and just go, go, and go. So this will be hip desensitization. Actually, we are testing extension on the other side. You agree?
Yep.
Yeah. If I need to add more pressure, again, one hand on the greater tubercle, one hand on the ilium, and in this case, I'll push him forward. So, can you stop? So,
Ganti.
forward. Okay, so I will push the ilium forward to increase extension. So now we are doing testing, active range of movement testing, loaded, and we did some overpressure at the end. Okay? So you got 5 minutes to do the advancing test or the range of movement test
Yep.
for the rotation, and to do flexion and extension of overpressure. We have to be super effective in our time management today. So when I say 5 minutes, it means 5 minutes. Okay? If the patient has a problem with lunges, we can do it from step standing, right? And in this case, it will be the same. Can we do it in this case? So same handling, one hand here, one hand with the ilium, and you will push down, and I will go forward. Yeah? Yes. Okay? So the same position, test and treatment. At this point, I feel symptoms. We'll do nice touch and go. My colleague is helping me with pressure by moving the ilium down. When you move the ilium down, automatically you go into hip flexion. Yeah? Good? So this would be another idea. Now, take a seat, please. Next is to do it from unloaded. If the patient can't do it from loaded, I have to do it only from unloaded. If the patient happy to do it from loaded and unloaded, I will do both. Why? Because from unloaded, I can do end range desensitization if needed. You will see that right now. Anyone has, you know what? Can I ask whoever wants, just do this right side. Good. And then do the left side. And if you have limited movement or pain, between right and left.
Left.
Is limited. Come please. And you feel the pain. Get ready. Come please. Sit down. Put your hand. Now, look at Russia. Guys, it looks like Rashid is Mr. Hassan again. So yesterday he had back, today he has been open. So right rotation, external rotation is limited. Can you show us the other side? Yeah, good. Now I will do the active and passive range from unloaded. Just take your shoes off and find your practice. I'll just do the basics. So this rotation external, right? Now I would like you to do this movement actively. So this is the available range. Now I will do it passively. There is no big difference between the active and the passive. This is the active, this is the passive. Tiny range. Good. I will go to the other side. Just move your heel out. Do it again. And the passive, no big difference. So this one is a good side. For flexion, relax your hand to the side, please. Okay. This flexion. Now, can you do this movement actively for me, please? So this flexion, I know that he's moving the head here, but it doesn't matter, because I will do the same in both parts. And this, any problem with that? To the other side, please. This one's limited. Can you do the other side again so everybody can notice? Yeah? Do the other one. Good. I will do it passively, slowly, because if it's limited, it could be painful with the passive. So just touch the water. It could be hot, it could be cold. How's that? No problem? Where? So you feel pain on the front. Okay? I will not make any diagnosis. I'll just say he has pain with flexion. So he has limited flexion. Your external rotation. This is the active one. There's a big difference between the active and the passive. Let's go laterally, internal. He's not happy. Yeah, he's not happy. Good. So what shall we do? We did the active and passive range. I will do from prone position. Can you go to prone position? I will assess rotation from prone position. After we finish this, you will talk to each other to make a summary. If you got everything, that's fine. If not, I'm happy to repeat again. So knees together, knee flexion, and ask him to drop.
Knee.
Yeah. I like testing rotation from prone because you can compare between both sides. Good?
Limit banget.
So straight away, he has mechanical head problem. This is all what I know at the moment. The only thing I know that it's a mechanical head problem, and he has limited range of flexion and external rotation. If I do some desensitization and the symptom decrease, is that good or bad? It's good, because if we confirm that the problem is mechanical.
Yep.
Number one. Number two, I will give him some self-mobilization as a treatment, and my next step will be the cognitive movement testing. If he failed, I will give him exercise to improve the motor control job done. Ready? Yes. Remember the shoulder? The three circles: pain, limitation, control.
And control.
This is all what we do with peripheral joints. Now, this mobilization is quite nice, and I would like everyone in the room to do it very well. And I told this from the Great Britain athletic team. When you do this mobilization, it can increase the stride length by 4 centimeters. Can you imagine if you are a 100-meter sprinter, 4 centimeters can give you a gold medal or a silver medal. But this improvement can last only for 15 minutes, which is fine. Rashid is not a sprinter, but he has symptoms. So I use this to increase the range of movement. Let's do that. I will do it on that side so you can see me, you can see my hand, and then I will show you the other side. This is my hand. I will find the greater tuberosity. Yeah? If you can't find it, there we go. This is a greater tuber. And I will place my femur and hypofemur on the top of the greater tuber. Can you look at his knee? Look at what happened with his knee. That's mean I'm moving the femur. If your hand is actually on the greater tubercle, when you press down, the femur will move. Okay? Please do a retest before I do my mobilization. This is quite limited here. Relax this now, please. Place my femur hypofemur on the top of the greater tubercle and hold the leg with the other hand, and I will press down. Good? And hold. With the other hand, I will do touch and go. So the touch and go with the left hand by moving the leg, which will move the femur. But this is sustained movement. Keep this, don't lose it. Too much pressure inside might irritate the sciatic nerve. So make sure that actually your hand on the top of the greater tubercle, not the ischial tuberosity. Okay? So sustained pressure, it's a big joint, needs big force. And do some nice oscillation or desensitization. Few times, and what's next? Retest.
Iritasi.
Yeah, I think you are masters of this now. Everything we do, we have to do a retest to know if it's red or amber or green. Knees together again. Bend your knees and just let your leg drop down. Good.
Mudah banget.
Green or amber or red?
Green.
So we can carry on. Good. So I will do it again. Down. But again, as usual, I have a good news and bad news. Yeah? You have more range, but you have to practice self-management. And this will be your task when you do the practical right now. To come up with one exercise at least to increase the range of movement of the hip, to flexion, rotation, right, abduction by self-management strategies. Right? So we'll do the practical right now, and then you will think about this other. Okay, that's enough. Retest. And retest again, out. Good. Can you line to back? If I retest, do you remember which other movement was limited?
Flexion.
Let's do flexion. Let's retest flexion. Can you retest flexion, please, on this side? Good. And then test the other side. Good. Good. I didn't use a belt. Some people use fascinating things. Where is my belt? I go with a belt in the morning to my clinic. No. Just simple stuff can make an effect. Now, I would like all of you guys on your treatment tables have a model and assess flexion, rotation, actively and passively. And then do this mobilization and see if there's any change in the range of movement. Number one. Number two, in your group, I would like you to discuss what are the self-mobilization strategies that you can give to your patient to do at home. And unfortunately, you only got 15 minutes to finish this.